Well, thank you everybody for coming. Thank you, Paul, for the invitation. And it's 8:30. It's the first talk of the morning. Thank you for all those people who are here. And I was tasked to talk about the top 5 innovations in the transcatheter aortic valve replacement space. And I gave myself a little leeway, maybe between 2018 and 2019. And there's been a lot of change that has happened over the last 15 years with the transcatheter valve world. Currently in the United States, we have 3 FDA-approved devices. You have the Evolut platform, the Sapien platform, and now the Lotus platform. And with that, I think the field has matured. But it continues to mature at a very fast pace, and we continue to be creative, which actually continues to advance and push the boundaries of our transcatheter valve replacement arena. So when I was looking at what to talk about, I decided to actually talk about 5 concepts, some of which were originally ideas that now have had good data behind them, some that have increased the population realm that we can currently treat, and some other ideas regarding valve biology. So the first concept that I was going to talk about is transcatheter valve replacement in the bicuspid valves. So this is a concept that's been relatively old. I remember when I started doing transcatheter valve replacements around 11 years ago, there was an article in JACC from the group in France that basically showed an expanded frame in a bicuspid valve in a patient who was post-mortem, and that showed that the frame was never going to expand completely. And that triggered a lot of hesitation as far as whether or not bicuspid valve patients should be treated with a transcatheter modality. Now, we've learned a lot since then, and now we actually know of different ways to characterize bicuspid valves, and I think the CT piece has given us a better understanding of who are the right patients and how to select them for a valve replacement procedure. In addition to that, I think there's been a lot of improvement in the technologies that we have available. And as you can see here, this is once again is previously published data from patients treated with both Sapien, Lotus, and the Evolut R platform. And you can see now that in patients treated with bicuspid valves, you have really similar results that are non-statistically significant, with the exception of a very large pacemaker dependency rate afterwards. Now, the series that were previously published were low in numbers, and it wasn't until the current TVT publication that Raj Makkar actually spearheaded that we can see now with over 2,700 patients and comparing bicuspid to trileaflet valve TAVR procedures, in which you see that patients are relatively similar in their age group, potentially in their operative mortality rate or risk, And what you can see is that patients who underwent transcatheter aortic valve replacement, granted in a registry fashion without a core lab adjudication, without potentially looking at the echoes and or the centralized interpretation of them, but you see that device success was actually very similar to a trileaflet valve. You did have a numerical higher grade of moderate perivalvular leak, however, it did not necessarily reach statistical significance. From a overall outcomes perspective, there was no difference in death. There was a higher incidence of stroke that you saw both peri-procedurally at 30 days and at 1 year. The pacemaker rate was higher as was expected, and there was a significantly higher rate of annular rupture. But all in all, this was still in the less than 1% range. So it is a relatively safe procedure in the appropriately selected patients. Now, should bicuspid TAVR be performed everywhere? I think bicuspid TAVR can be performed, and it's up to us to decide who it should be performed on. So I think that was one of the biggest advances this year. You can't talk about TAVR this year without necessarily talking about the low-risk trials that were presented at ACC. Both the Evolut low-risk trial and the PARTNER 3 trial were remarkable. They actually will expand potentially the treatment the patient treatment realm that can be seen hopefully over the next year. And if you remember in the Evolut trial, it basically randomized 1,400 patients to either surgery or treatment with TAVR in utilizing one of 3 prosthetics. It used some of the old core valves, some of the Evolut R and some of Evolut Pro platforms. And the combined endpoint of death or disabling stroke at 2 years was found to be non-inferior, both in the surgery or the transcatheter valve realm. Patients with TAVR had a higher risk of perivalvular insufficiency and had a higher rate of pacemaker dependency. However, there was lower risk of AKI and postoperative atrial fibrillation. So with this non-inferiority trial, this gave, once again, one more leg for potentially expansion of the treatment arena. The PARTNER 3 trial randomized 1,000 patients, both to surgery versus transcatheter valve replacement. They're all low risk. The mean STS score on both was around 1.4%. And you can see that the combined endpoint of death, stroke, or rehospitalization actually was markedly lower in the transcatheter valve realm as compared to the surgical realm. Patients who underwent TAVR also had a lower rate of stroke and/or death or stroke, the lower rate of kidney injury and/or postoperative atrial fibrillation, and also felt better a lot quicker, which is something that was echoed in the all other trials that were previously published. So with this data, I think once again, this gives an extra advancement on the populations that can be treated with transcatheter valve replacement, and hopefully will continue to advance. Bioprosthetic valve fracture and bioprosthetic valve remodeling is also something that we've learned a lot more. Previously, it was just considered a concept with case series here or there. But now, with larger data that was recently published also, we begin to see that there's a bigger place for it. If you remember, in the valve-in-valve registries for CoreValve and for PARTNER, there was a mean grade around 17 millimeters of mercury after a procedure. And we know that there's a higher association of mortality with this. And now, with the utilization of a non-compliant balloon modifying the intrinsic valve, we can see that the gradients drop almost in half after the procedure is performed. As you can see here, this is the result immediately after a valve replacement is performed, and then this is what happens after you crack the valve. And as a result, this may actually improve the outcomes of patients after they're treated with this type of pathology and technology. Also, Adam Greenbaum spearheaded the concept of electrifying guide wires, and I think the concept of having complications from valve-in-valve procedures like coronary obstruction, although not frequent, they're definitely not inconsequential, and as a result, the concept of Basilica was developed. Basilica, as you guys remember, is the laceration of the coronary leaflets of the valve in order to prevent coronary obstruction. And I think with the work that was previously done, we now have a multi-center registry, which actually shows that there is there's good success. There was a 93% primary success rate with 100% absence of coronary obstruction. The safety endpoint was not necessarily one that's very appropriate. However, the majority or all of these safety complications came from bleeding complications from the TAVR sheath, not from the Basilica perspective per se. And patients actually did have hemodynamic instability, which was transient, only around 7% of the time. So potentially Basilica is a good treatment option for the appropriately selected patients, and there's a question of whether or not it actually may improve sinus of Valsalva emptying in order to prevent valve thrombosis. The durability of valve prosthetics is something that we all begin to ponder on, and it's important for us to know that there's no prosthetic that is perfect, whether surgical or catheter-based. And I think that's where the next big advancement in valve replacement will come from, not necessarily in modifying the frames, but modifying the leaflet tissue that is utilized. And there's two advances that actually I think are important to make note of. One is, Edwards Lifesciences has recently commercialized a new way of treating their valves to minimize the calcification called Resilia. There's another company called Admitus that actually has modified the ADAPT technology, in which both of them, the primary desire is to remove all cellular remnants from the bioprosthetic tissue in order to prevent calcification while still modify the cross-linking properties to improve the feasibility and the flexibility of the leaflets and minimize toxicity. So with these advances, hopefully we'll get better, longer, durable valves. So it's been an exciting year in the field of TAVR. There continues to be advancement both in indications, patient selection, and techniques to minimize complication. And I think tissue science and leaflet design will be the next big field where we'll need to continue to work on in order to have the perfect prosthetic. Thank you.